Oh, one thing I didn't ask. Are we recording this?
We can. Do you know how?
I'm just trying to figure it out.
I think it records automatically.
Amazing. Okay.
That's what I've heard.
Okay. So that's fine. I think we'll get well. So, hi everyone. Welcome to the second session of the PSA series, which is on planning management and communicating information. So the session will be taken by myself and Alex today, where we'll be going over the topics that I've just mentioned. And while we're giving time for more people to join, we just wanted to let you know about a research project that we're undertaking as part of MedTic this year, which is on the QR code on the screen at the moment. So if you do scan the QR code while we're just waiting, we're going to start in the next 2 to 3 minutes, so it wouldn't take too long. So if you just feel free to scan the QR code, I'll also pop the link in the chat, which you should be able to have access to, and then we can just do that in the meantime while we wait for people to join. But yes, welcome to everyone for who's joined so far.
And just throughout the session, if anyone has any questions about what we're going to cover in this session or any other PSA related questions, feel free to pop them in the chat and we'll answer throughout. Okay, shall we start?
Yeah.
So in this session, we're going to cover planning management and also communicating information. We'll have several practice questions on each topic, and we'll go through them. We'll let you guys answer them, and then we'll go through the answer and how we got to them. And we'll also have a top tips medicine complete bit at the end. So I'll take the planning management part of this session. So planning management comprises of 8 questions, 2 marks each. So it's about 1 minute per question. It's probably a little bit more than that, but for the sake of this, we'll give you 1 minute per question. So it is very time pressured, which is why you need to be quite efficient with using Medicines Complete. And we go over what sort of topics can come up in this, but the main parts of the Medicine Complete that you'll want to use are treatment summaries, drug monographs, but it's also really key to have good knowledge of sort of condition definitions and sort of knowledge around different medications that you can apply to the question to quickly rule out some of the answers to speed up your process when you're answering the questions. So this is the format of the question. So it's single best answer. So you just tick the right one. You read the stem. What's important with actually reading the question is the wording. So you can see, for example, here it says most appropriate. So there might be several of the answers that could be appropriate or important. That's the other word they like to use. But it's which one is most important. So then you need to use a bit of your own clinical judgment. So the next slide, this is question 1. So read it and answer it. We'll give you a minute starting now. Okay, so that's 1 minute. So the answer was D. So you switch omeprazole to famotidine. So the reason why you take her off her PPI is because she is having her OGD in 4 weeks for this GORD, and just given a bit of the sort of the presentation, she'd be worked up here for a query malignancy. So if we go to the next slide. So because the OGD is being performed to try and rule out cancer, it's important to take the patient off the OGD because it can mask signs and symptoms of gastric cancer. This is found through the BNF. This is quite a tricky question. It's a bit of a tough one to start on, actually. But essentially, if you go to the drug monograph for omeprazole, go down to the cautions, and you can see this point, which would sort of help you with. You'd like to think that you'd have some background knowledge in the fact that you think about stopping PPIs before an OGD if it's not an acute situation. So putting these two together can help you get to this answer. So as I said, it is a tough one, but the answer is there in the BNF if you looked hard enough. So we can move on to the next question. So if you read and answer this question, we'll give you a minute.
So the minute is now up as well.
Okay. So we can go to the answer slide. So the answer is A, because this patient's had an elective surgery and they've been started on a variable rate insulin infusion. It's important to know that this can be found in the BNF and we show you where, but it's important that you give their long-acting insulin with their next meal, and then you continue the variable rate insulin infusion for an hour before you discontinue it, just to give that long-acting insulin a bit of time to kick in. This can be found through the BNF if we go to the next slide. So this is in the treatment summary for diabetes, surgery, and medical illnesses. So if you search that up, and then it sort of details within that document where that information is. And there it is, so the conversion back to the subcut insulin. Okay, so we go on to question 3 and we give you a minute.
The minute is complete for this question.
Okay, so the right answer is the oral erythromycin. So if we go to the next slide, we'll show you how to get there. So that there's a section in the treatment summaries for prophylaxis for antibiotics, antibacterials. So the question was sort of hinting at which prophylactic. So it's good to know that this is one of the treatment summaries, and then in this section you can go to the prom section. And if you go to the next slide, if you scroll down, then it shows you erythromycin. Then you'd go through the erythromycin monograph to find the specific dose for that for erythromycin to be used to treat in prom. So that should have been a more simple one to find the answer to, rather than digging through lots of text. So move on to question 4.
minute is up.
Okay, so this question sort of involves less use of Medicines Complete or the BNF, and sort of more clinical knowledge. So there's a diagnosis of DKA, and this can be seen through the VBG with the glucose more than 11, the pH less than 7.3, and then the bicarb less than 15. So you won't find the exact DKA treatment summary within the BNF. However, this just involves requiring your own knowledge. It's a bit simpler than actually prescribing, because you just have to click the right answer, which should be in the fluids with the fixed rate insulin infusion. So it is important to familiarise yourself with managements for common emergencies, medical emergencies, and we've got a few here. So DKA, HHS, hyperkalemia, hyperglycemia saves you a lot of time in the BNF in the exam to be able to draw on knowledge of these, rather than trying to search for the answers that may not actually be in the BNF. And actually, you can sort of use less than a minute for this, and then you might be able to use more than sort of the time you originally were going to allocate for other questions, for ones that you might need a bit more digging in the BNF for. So the last question for this section.
The time is up for this question.
Okay, so yes, so if for this question, you had to realise that the patient was palliative. So it's going to involve us having to convert initially work out his new total daily dose of opioid. So it's the 80 plus 40, so that's 120. And then because he's palliative, it would be worth converting him to a patch. So if we then go on to the next slide. So this is a screenshot from the treatment summary of prescribing in palliative care. So we can go to where it says 120. So we can get the conversion dose to the fentanyl patch, so the 50 micrograms per hour. And then the reason why you'd still have the breakthrough dose, so it's a tenth to a sixth of the total daily dose. So you have to sort of use a bit of common sense here. So 12 milligrams would be a reasonable breakthrough dose, and you'd prescribe that as oromorph, so immediate release. So it's good to know that the opioid conversions. So this is converting morphine to fentanyl patch, transdermal patch, but there's also different opioid conversions from oral to subcut, and different strengths of opioids as well. So it's good to know that about this treatment summary. So the reason why we put them on a patch is because the STEM hinted at the fact that they were palliative with a terminal diagnosis. So if we go back one slide just to get at the STEM. So it's not something that you'd have to it's more the most appropriate option, and that's sort of why reading the questions always key, because I agree there's more than one correct answer here, but it's the most appropriate answer. Okay, so this is sort of explaining more of that, and I just want to go back to the question 2, because I think there was a bit of confusion. So if we go back from the slides, this is the insulin around surgery question. So you administer the short-term insulin, and then after an hour you can discontinue the variable rate insulin infusion. So it's not the long-acting; it's the short-acting that you stop, and then that you give them with their meal, and then after an hour afterwards you stop their insulin infusion. So I just wanted to clarify that. And then there's another question just about why switching to fentanyl, and it's more the fact that you're switching to the transdermal patch, and that's just the formula that it comes in as fentanyl rather than something like morphine. But then the breakthrough is always going to be oromorph, so immediate release morphine. So that was for the last question. So I think we can move on to the next communicating information section now.
Yeah, so the second half of this is going to be about communicating and providing information. And someone just put a question in the chat about whether you get access to medicines guidance in the PSA. I'm not sure what you mean by medicines guidance. So the two things you can use are Medicines Complete, or the direct BNF website, which will be available through the portal for the PSA exam. So you do have access to use either Medicines Complete or the BNF, depending on what you want to do. Hopefully that answers your question. If not, put more details in the chat and I'll answer it later on. So this is just a question showing the format of the provided information question. And so it's essentially 6 questions that you're going to get on this theme in the PSA, which are worth 12 marks in total, because you have 6 questions worth 2 marks. So it's going to be 12 out of the 200 marks you get in the PSA. Again, we're suggesting about a minute per question. As Alex said, you might have a bit longer just depending on how you choose your timings. But the timings we're working with for today, just to kind of get you in the zone, I guess, is basically just a minute per question, just to see how time pressured it can be at times. But obviously, depending on how you manage in other sections, you might have a bit more leeway in terms of a minute and a half or slightly less, depending on how you get along. Just answer the question about prescribing in palliative care, and the treatment summary is part of the BNF, but I see in medicines guidance. Again, what do you mean by medicines guidance? Is that a section of the BNF that you're referring to, or is that something in Medicines Complete? So I'll leave us to answer that in the chat a bit later on. But yeah, this is just a question showing the format of the providing information or communicating information aspect. So with that, I'll leave you to go straight into the first question of the section, and I'll start the timer, or Alex can start the timer, and in a minute's time, we'll let you know when to stop. So a minute's complete. So I'm going to move on to the answer. Someone's put D, and that's great. As I said, guys, honestly, I think the best way you're going to get the most out of this session is by getting the BNF or medicine's complete up and putting in your answers, just seeing what you come to, just so you get a good practice in. Um, so, um, yeah. So the answer for this question is A. If the person who's put D in the chat just wants to kind of, talk through why they thought that was the answer. If not, that's fine. But I think, a lot of these things, it's important to kind of just know what, that they may all be right in a way, but it's more the most important information in that, think safety, what is going to harm the patient, or what is going to be the most important thing that they might be worried about that might cause them to maybe stop a medication without actually recognizing. So think about common side effects that they might need to know of, or dangerous side effects that if they weren't informed about might cause them to stop taking the medication, because what you want to promote is patient safety at the end of the day. So if you do look in the BNF for so someone said, why not E? So having the LFTs prior to starting treatment. It is under monitoring requirements. Yeah, so it is. Yeah, so there is. So going to the question, Amani answered that in a way, because you said, I thought it was only contraindicated with active heart failure or increased risk of heart failure with insulin. That is one part of it, but then she also has risk factors. So if you look at the past medical history, you can see that this is a patient who's had a previous MI with a history of hypertension. So her cardiovascular risk means that she is at high risk of heart failure. And in that case, this is a diabetic patient, previous history of cancer, so multiple comorbidities and specific cardiovascular risk factors that make a high risk of heart failure. So even though she's not on insulin, it's not that it has. So she doesn't have to be on insulin for her to be at risk of heart failure. It's just the risk is even greater if she is on insulin. So I think that's where we need to be careful with the question. So they might ask you something like this very easily, and it's not the most obvious stem in that they don't tell you that her risk is going to be greater. But looking at things like past medical history, drug history, renal function, things like that, if they provide it, they don't provide that information just for the sake of providing it. So I think just look at other elements rather than the obvious things. So someone's just said they've seen in the caution part risk factors for heart failure. So yeah, as I said, all of these things, well, most of these things probably will be relevant to think about. But again, it's not contraindicated with patients with active or previous breast cancer. It's more related to bladder cancer. So they might catch you up with things like that. So some things might look familiar. So you might know that pioglitazone is, contraindicated in someone with a certain cancer. And so if you don't remember off the top of your head, you might be tempted to go for the breast cancer. So just be careful and pay attention to things like that. So hopefully that clarifies why A is the answer for this question. So we're going to move on to the second one. Just before we do that, there's some important sections when it comes to communicating information and providing information, really. So a lot of the questions will probably be related to the points with the arrows. So things like the important safety information that patients need to know, contraindications to things, side effects that patients need to be aware of. Things like pregnancy and breastfeeding will be one of the things that might be considered in the questions. Thinking of hepatic impairment or renal impairment and monitoring requirements, and things like patient and carer advice. So it's going to be one of these sections. But the best tip I can give is Control F, because obviously, whilst it's going to be in one of these sections, you don't want to go through every single one of them unless it's obvious what kind of question they're asking you, and then you can know which of these sections to go to. So still Control F things and try and find that the quickest way you can. And if confused, just go to one of these sections, which will hopefully give you some information. So, moving on to the next question, you have a minute for this. As I say, please pop your answers in the chat and we'll talk through them. So the 1 minute is up, and well done to those who put C in the chat. The answer is indeed C. And I think it's one of those things just to be aware of. So some people might think, oh, methotrexate and any other medication that involves contraception might be only for the female involved, but some medications do require a male patient to also be on effective contraception, and so it's important to think of it from that perspective, and don't just basically think of ways. They're not trying to catch you out, but it's important to just consider important information and think and actually just look in the BNF if you're not sure. So I think this was quite a straightforward and easy one to find. And so if you have any questions, let me know. But it's quite straightforward. And I think I just kind of put some information about things like methotrexate. It's just important to know some drugs that are commonly asked about or that can be easily asked about. Things like the fact that it's weekly and not daily in most indications. Contraception is needed for both male and females during treatment for at least 6 months after. Folic acids on the days that they're not on methotrexate, because it's an antifolic, so it's kind of pointless taking it on the same day. And avoiding things like concurrent NSAID use, because obviously there's increased risk of renal toxicity. And so if both medications have increased risk of renal toxicity, it might be worth, giving them some counseling and advice about, other alternatives for things like pain management, and things like reporting any features of any blood disorders in terms of side effects and risk of photosensitivity reactions and medications that they interact with, which might come in handy in other sections as well. So things like trimethoprim or cotrimoxazole, because cotrimoxazole contains trimethoprim, and so both can increase the risk of hematological problems. So basically, if they have a UTI, that could easily be a question. And what might be the important thing for someone on methotrexate to know in terms of the management, or for the GP to know. So that's another thing that I noticed when I was going through the blueprint. So it's not always just information for the patient to know. It might be something for, it might be you're the GP, and what's important for you to realize in managing this patient. So it's important for what the patient needs to know, but what other healthcare professionals might also need to know in managing this patient safely and appropriately. So just think about things like that. So a minute for this question and we can talk through it. I think most people have got the answer for this as well. So I'm going to head over to the answer, which, is you guys have said, is the up to 10 puffs of the salbutamol inhaler can be used. And this is one of the ones where it's not in the treatment or the drug action itself. So if you tapped into salbutamol and looked for it that way, you wouldn't find that information. This is something you needed to find in a treatment summary for asthma, acute asthma. And so I've highlighted how you find it, or where it says that. So maximum of 10 puffs vice spacer can be used while awaiting medical attention. And so this was obviously in reference to children aged 2 and over, but yeah, so that's where you need to find it. So thinking about where you might find things, because if you typed in salbutamol, you wouldn't have found this. It would just say something like users directed or something random that gives you no information that's useful to you. So just think about things like that. And it does, yeah. So because this is a pediatric patient, you could also find it in the BNFC. But yeah, I went through just the BNF itself, and it provides you for both children and adults. So as I selected this was someone 2 years and over. But it is always good sometimes to check the BNFC if it is a pediatric specific question, because there's some things that come up in the adults for both peds and adults, but sometimes there's some information you will only find if you search for the BNFC, which is a good point. Yeah, so then the next question is this. You have a minute. Yeah, so a minute is up for this question, and well done to those that answered it correctly. And so the answer is C. Someone said B or C. And yeah, so I'll explain that in a second. I'm just looking through the chat as well, just to see some of the questions that came through. Someone asked in the chat if you get access to BNF treatment summaries. So you do get access to the treatment summaries. So yeah, what we're telling you is things that you would find. Yeah, so you would find access to things like BNF summaries. You just wouldn't be able to access things like the nice CKS. So when people sometimes look for information, they look in things like the clinical knowledge summaries. You wouldn't have access to that. So you would only have access to treatment summaries and the actual medication information itself. So you will have access to that. So I hope that clarifies your question. Yeah, and I think someone else has just said that as well in the chat, which is perfect. And so yeah, so I wasn't referring to the asthma question in terms of things you can find specifically in the BNFC. So I remember when I was doing my preparation for PSA last year, and there was a question. I can't remember if it was in the mock or some sort of practice I was doing. I don't know what the question was because obviously it's been a year, but I didn't find it. And a colleague of mine also, we couldn't find it in the BNF at all. But when we checked in the BNFC, it was there. So I think just as a matter of caution, if you do find a question about pediatrics, I think you don't lose anything by going directly to the BNFC if you know that the question is targeted to the pediatric population. As I say, the adult will have pediatric and adult stuff sometimes, but I think it probably is just a safer bet to go straight to the BNFC. So hopefully that clarifies that. Yeah, so the answer to this is C. And I highlighted where it shows that in the BNF, which it says babies of mothers taking warfarin at the time of delivery need to be offered immediate prophylaxis with IM vitamin K. And I think, as I say, some of the things someone I think said B or C. Yes, the baby's at increased risk of having fetal abnormality, which would be important information to know. But at this point, she's presented in labor following a concealed pregnancy. So her knowing that isn't going to change anything at this time. Is too late. Whereas if this was someone who was, at an antenatal clinic, say on warfarin, then I would need to tell her that, while you're on warfarin, then your child has a risk of having a fetal abnormality. Is there something else we can try? So antiphospholipid syndrome, she wouldn't be able to be on a DOAC. And so it's just things like that, trying to think of management. But in this case, the best thing to tell her is about what needs to be done following the fact that she's in labor. She needs to have this child, or she's going to have this child. So what we can do in terms of safety for her and, her baby, is immediate prophylaxis with IM vitamin K. So hopefully that clarifies why this is the most appropriate. So just think about the context, and then we'll go from there, if that makes sense. But yeah. And then the final question for this section is this. So 10 minutes, 1 minute to go. Yeah. So the minute is up, and well done to everyone who said E, which is the correct answer. So I think clozapine monitoring, when it comes to psych, there's a lot of things like lithium monitoring, clozapine monitoring are topics that are easily testable. And so it is important to know that, because patients on clozapine risk of agranulocytosis, they kind of need to know how to basically ensure, look out for signs of infection, as this can have serious impact on the patient. And so that would be the answer to that question. And in terms of finding it, as I said, there's different sections which are relevant to things like that. So the section to look at will be the things like important safety information. If you're going on the section method of looking for important information, in which case it talks about things like infection and looking for signs of clozapine toxicity. So we definitely need to make sure that carers are aware of things like that. And so that brings us to the end of the questions with regards to communicating and providing information. But one of the things I would encourage everyone to do is, again, just have a detailed look at the blueprint, which I'm sure you guys would have done anyway, because they do kind of give you clues as to what kind of things can come up. And I've kind of highlighted that on the screen. So things like insulin is an easily testable topic that they're probably going to test you on or may test you on. Warfarin, salbutamol inhaler, methotrexate, and oral hypoglycemic, which I've tried to incorporate. So the oral hypoglycemic being things like the pioglitazone, but also knowing glycosides, so the risk of hypoglycemia with sulfonylureas and things like that. Metformin, stopping it in lactic acidosis. Someone comes in, there's something about high lactate in the stem, or any other thing that can point you to that diagnosis, because some of the things are indirect. So they wouldn't tell you the person is in lactic acidosis. They might find a roundabout way of telling you that, but it's kind of picking up on the information that they're giving you. So I think, DOACs, HRT, things like that are very easily testable topics. So just have a look at the blueprint and see what they say that they're going to test you on, and look through the BNF to kind of know as much of that information as possible without having to search, because that saves you time. And someone says, do you get 2 screens or split screen in the PSA test? I think I remember splitting my screen. I think that is the best way to kind of do things. So you can split your screen unless anything's changed. You can split your screen. Yeah. And so in terms of blueprint, so again, going back to the blueprint, so the information from them about this station or this part of the exam is that, it can be about clinical scenario where someone needs information about medicines. But as I said earlier, it could be a request to identify the most important information that should be provided to a patient, a carer, or a healthcare professional. So the only thing I didn't do was do a healthcare professional situation, but it's sometimes for the patients, for the carers. But remember that could be a doctor to doctor question, whereby, a GP needs to know something about medication started by a hospital specialist like methotrexate, or vice versa. So don't forget that. And then you need to select what's the most important information, even if other things are seemingly correct. And the other part is what I found interesting from the example that they gave from the MSc and everyone involved in the PSA was this question about using language that is appropriate for the intended recipient. So if you look at the options from this question about things to let a patient know about warfarin, it says, and so the option C says warfarin sodium therapy reduces the risk of a second DVT and increases likelihood of bleeding. And so it's just things like remembering that, whilst you might say something that's important, will the patient understand what you're saying? And so just making sure that what you're saying, so they might give you 2 things that are pretty much similar or the same, but what is the impact of what you're saying on the person that you're saying it to, if that makes sense? So just try and use patient-friendly language select one with a patient-friendly language if it's something you're communicating to a patient or a carer, for example. Whereas if you're communicating to a healthcare professional, then the answer you select for a certain question might be more relevant in that situation. So hopefully that makes sense. So just read the question carefully and think about who your appropriate recipient is, as that might determine what the most appropriate answer is in that situation. And again, they are very helpful. These are topics that they could test. I think obviously we haven't gone over every one of these tonight, but I think a lot of resources are out there that can help you with things like that. But focus on these things so that you can, because these are the things that telling you that you're going to be tested on. So it will be related to things like that. You know, some of the things that are not commonly thought about are things like vaccinations. You know, what advice might you need to give, or what might be the most important information to give regarding vaccinations? Maybe things like live vaccines, when can or can't they have things like that? So just think about things that are not the common, you know, clozapine monitoring or, you know, HRT and contraception related stuff like, you know, anti-epileptics and teratogenic drugs. These are important things to know, but also think about the less commonly, I guess, spoken about areas of this. So use the blueprint to kind of guide your revision. So hopefully that helps. And I hand over back to Alex to talk through.
So this is just going over some general PSA top tips. So we've spoken a bit about, or we've sort of used interchangeably, Medicines Complete and the BNF. We'd always recommend Medicines Complete, just because there's a few features that mean that it's more easy to like search information, and essentially all the information in each is the same, but actually being able to find it we think's easier on Medicines Complete. And one of the things they have is the interaction checker, where you just type in the names of drugs. So you just type in the name of drug, enter, so on and so on, and then it sort of brings them together and it tells you the severity of each interaction, if there is any, between medications that you've listed. So you can split the screen. I know someone just asked that, and we've covered that. Get used to using Control F. I'm sure everyone knows how to use it, but it's key to just quickly going through information. And when you're reading the stem, always make sure you sort of pick up on keywords that you might be able to put into Control F. So someone, I just reading the chat, someone's just asked where to find the interaction checker. So it's hard. So for some reason, because we're not a university, we're not on trust, like hospital trust computers, we can't get Medicine Complete on our like personal laptops at the minute. So it's hard to like show you where that is. But just off, someone might be able to answer in the chat that actually has already sort of like found this. But I believe you go through a drug monograph. So just any old drug monograph, and then on the left hand side, if you scroll down a bit, there's something that says interaction or interactions, and I think if you go on, then there's a search bar. That's the only way I found it, but you may be able to find it some other way, but that's only on Medicine Complete rather than the BNF. Another key thing about Medicines Complete is you can search terms. So say you wanted to try and find a medication that worsens heart failure, you could actually search heart failure and worsens, and it will come up with sort of different medications that have those two terms in it. And that's not necessarily saying that it worsens heart failure, but it's saying that it essentially means that those two words are found within that drug monograph, and then you can go through the drug monograph, Control F, heart failure, see if it does say worsens heart failure. One of the other things with search terms is you can put abbreviations into Medicines Complete, such as COPD, rather than writing out the whole disease name in full. So we can go to the next slide. Another really useful section of the Medicines Complete /BNF is Appendix 1. So you can just search it through the search bar, and it has a list of tables in alphabetical order of drugs that come under these specific headings. There's 20 tables. I've highlighted the most useful ones, such as nephrotoxic, prolonging QTC, hyperkalemia, among a few others. Just if you get stuck, obviously it's good to know your nephrotoxic drugs, but some of the other ones, you might forget it on the day, and this is just an easy way of finding it. But it's also good to know what isn't included in this, so you don't waste your time trying to find one of these drugs in this section that doesn't actually exist. Go to the next slide. And then just talking about treatment summaries, just get really familiar with which ones they are, what they're actually called, because, for example, infections, it's not cellulitis, it would be under something called skin infections, or eye infections. It's not conjunctivitis, it would be under eye infection. So you have to just get used to sort of navigating them. And then you have some more specific ones, such as medical emergencies in the community, just knowing what's included in that and that it exists. Poisoning is another one. So it's difficult in these sessions to go through all of them and have questions touching on all of those, but we try and give you a flavour of what's included. But it is key, just maybe spend a bit of time to just going through them and reading what sort of information is in each one. Just spending 10-15 minutes doing that can actually really help in the exam. That's what I found, at least. And then this I've just included because I know we haven't fully covered calculations yet, or fluids. So this might not be the most relevant thing right now. But if you're really stuck with some of your calculations, especially something like what does 0.15% concentration mean? If you just search up the fluid, so the standard one, sodium chloride with potassium chloride and glucose. So you just type that in, then you go to the medicinal form, and you can drop down on one of the drugs. It doesn't matter which one, and it sort of just explains what 10 milligrams in 1 milliliter equals 4%. So you can do these calculations yourself, but in the heat of an exam, your mind might go blank, and it's just good to know that you can find this information in the BNF, and then you can sort of extrapolate this to whatever calculation you're doing. But it's just sort of it's getting you your concentrations correct. Okay, that's so yeah. Any questions? I think we try to answer as many as we can in the chat. Does anyone want to? Okay, a few are coming through now.
Yeah.
So in terms of sorry, you go.
Sorry, I think I just saw the one about medicines complete, and is it only through our organization or personal computers? So it depends on your university. So our university had access that we could log in when we are at home, or at uni. So it just depends on what access your university provides you, really. So you should be able to access it via your personal computers. And depending on, I can't remember the time frame. I think naturally once the PSA website goes live at some point anyway, it will start letting you practice with both. But I just can't remember how long the timing between that is and your actual exam. So I don't know if Alex wants to add anything to that.
I think I got it from my university, if I'm honest. But if you have some sort of trust organisation access as well, it will be on that. But it's worth getting familiar with it. And then, how do you interpret some of the interactions? So when you say interactions, is that between medications? Oh, this combo increases risk. It would sort of depend on the question, I think, if you'd consider it, like how severe it would be, and if there's another interaction out of the list that is more significant, I think. So that's sort of where the clinical judgment comes into it.
And I think just to add to that, I think sometimes it does come up with a severe. So when you do put into medications in terms of interactions, if it comes up with a severe, then you absolutely don't want to give that. But sometimes it just comes up with like an interaction, but not like a severe interaction, in which case, it's trying to think about which one is the most relevant to the question that you're being asked. But there are some that will come up with like a red severe, if I remember correctly. And obviously those ones you wouldn't want to give a patient. Whereas if they do just come up as a generic may and may not, that's where you kind of have to use your own clinical judgment and inference. But if you use the interactions checker, it does come up with some that kind of stand out as a no.
And then I don't think there's any other questions. We'd really appreciate feedback, and we've dropped the feedback form in a few times in the chat. Just really helps us with providing high quality sessions. I think the only other one is someone asked to go back to the slide on Appendix 1 as well. Was there anything specific regarding that slide, or no worries if not?
Yeah. And just to add to that, I think, a lot of people, when they find this out, think it's the best thing in the world, which it is, because it's great. But I was just saying to Alex before we started the session, I remember there was a question that we would have expected to find in Appendix 1 in our PSA last year. Because it was asking, I think, about an electrolyte abnormality. I can't remember exactly what it was, but it was one of the topics in Appendix 1, and the actual drug was nowhere to be found. So I think under that section, so I think it is very useful, and I think definitely go through it and know that it exists, because it does save you. It does save you in the exam wasting time just thinking about things that you can just find very easily. But just be mindful that if it is a basic or common or something that for some reason they expect you to know, it might not be in Appendix 1, and you just might have to use your clinical judgment and kind of think about what the question is really asking you, and then try and decipher the information from there. But 100% agree with Alex. I recommend this, but just to be aware that don't think, I don't need to remember anything because it'll be in Appendix 1.
Yeah, and then just the last question there about fluids and fluid concentration. So we haven't actually covered fluids. It didn't come up in the previous session. It didn't come up in this one. We will go over that in one of the later ones. So that's why I thought that slide I put in, it was more just part of the top tips to know that when you come to sort of practicing your fluid concentrations, that's there. But we will go over in detail how to calculate the specific amount of each like electrolyte that you'd need in a fluid, because it's based off weight of patients. So I think that's concludes the session, unless there's any other questions. Okay, well, once again, thank you very much, everyone, for attending and providing some feedback. Our next session is next Thursday at the same time, 7 p.m. So we look forward to seeing you there, and you'll hear more about it on our social media pages. Thank you very much.